Myself, I'm a play specialist here in CUH for 5 years. I was on my own for 3 years, and then I had a colleague for a period of time. And I just adore the work that I do. I find that it is the most amazing, rewarding work that you can ever do in the world. And I love sharing. I suppose I'm very passionate about sharing what I know with parents and other professionals so that we can make a bigger impact for children. Being in hospital is never nice. I don't know any child that really enjoys hospital, but I am told on many occasions that a lot of children are looking forward to coming to hospital because they're looking forward to seeing me, and they're looking forward to the play and the interactions that we are going to have. So that is beautiful. That's a real testament to the power of play. So I'm hoping that tonight I'll be able to give you some of the strategies and some of the supports, and I suppose emphasize the importance of play. So the toolkit for today. Now, will this actually... Sorry, getting it to change slides. So I suppose starting out, the thing about childhood, our childhood is so significant and distinct time of life for us to need to be valued, respected and nurtured. And this is the most important thing when we're in the hospital, that value, respect and nurturing. Yes, we're in medical situations, but we need to look at what's important to that child in that moment. So each child is so unique. And Emma, you've hit on that beautifully about Harrison and Blake being so different. Every child is different. And again, nurses, doctors, whoever is involved in the team, down to the cleaners that come into the child's bedroom, we need to know what works for your child because they are so different. And if I use an approach like trying to be friendly and play... So sorry. So somebody asking a question? Sorry,
I joined late, a bit late to the meeting. I'm Jahanara.
That's okay. Welcome. Yeah. So I'm Rachel, I'm the play specialist. I'm just going to take you through a couple of slides in relation to a toolkit for parents and just in general for what can support a child in the hospital. So just talking about the individuality of the children really, and their strengths, their rights and their needs. And that's the backbone of the work that I do. And for you as parents and professionals working with children is to advocate for them and to empower them to really have their own voice where possible. But in cases like Harrison, he doesn't want to have his own voice in the hospital. He wants Mammy to be his advocate and he wants to tell Mammy what happens and then Mammy tells. So it's respecting that. So I suppose power is play. Play is power. So play is the language of all of our children. And like these are two lovely quotes. So the one around play being a medium through which children interact, explore, and make sense of the world. This is so important for the hospital because the hospital is such a crazy, strange environment for children. And for them to be able to make sense of it and explore what's actually going on, they need to be able to play. That is their language. That is how they process what's going on around them. That's how they work through everything. And it is not only that, but it's also the joy and fulfillment and the happiness. Laughter, our brain doesn't know the difference whether we are laughing, like properly laughing, or if we are fake laughing. It doesn't matter. The same hormones are released in our brain. So by bringing laughter and play to children, like I walk into rooms and sometimes children are so flat in the bed, they're barely like whispering and talking to me. And within 10 minutes, they're a different kid. And the parent is going, whoa, what happened there? Because the power of play, playful interactions, and taking it at their pace. So again, the feelings of stress and boredom that come with hospital are quite big. Some of our children spend a lot of time in hospital. Some of them, it's a fleeting visit. Either way, it needs to be a playful experience for them because play is what they need. With stimulating creative thinking and exploration, this is really important around the hospital piece. Kids love to explore new plans and how they want to do it. So that's my big job with them. It's like, what's our plan? What's it going to look like? And doing that in a playful manner is the key. Play is important in regulating emotions. Like emotions are high for everybody involved in a hospital visit. There's no hospital visit that doesn't have high emotions at some point in time. So being able to use play as the modality for them is the key to getting them through it. So some of the research around embedding play in pediatrics around the communication. Again, communication I'll talk about a little bit later. Again, communication is key. Allowing children to increase their understanding of the world and what's happening around them. Hospital's very alien. Some children are exposed to a lot. Some children, it's very new. They don't know what's happening. To impact on the way in which they cope with the events of what is happening around them and reduces the fear and anxiety. That, I suppose, is the biggest one. I think that's probably what most of you are here for, is how can I help children to have a less fearful and less anxious visit to a hospital. So play being the vital way for them to gain agency. This is the most important part of it all. They need to gain agency in their treatment. It's their body and it's their health is at risk here. This is what we need to look at. We need to name that. We need to acknowledge that it's their journey. And giving them a sense of control and autonomy is massive within that. And that's where you see a total change in a child. Like I've people at the MRI team call me the magician. I am not a magician. I don't do any magic. I help a child to see the power within them, to believe in themselves, and to be able to get through things. And that is by giving them a sense of control and autonomy, helping them put a plan together. But it's their plan, it's their words. I'm not coming with all the answers. I'm actually coming with a toolkit that can help me to help them. But I'm not coming with the answers, because the answers are with them. And that's what we need to explore, is how we get that out. And that's very different for every child. As you said, Emma, Harrison and Blake are very different on that. And so how we go about that is going to be very different. Play will help them to express their thoughts and feelings. So I will be sitting in a room with a child and they will be playing, and that's where everything comes up. All of the information will start coming out. So for parents of children, when you are in those kind of laid back experiences, when you're back at home after something has happened, or when you're playing before you go to the hospital visit, again, just sitting and playing with your child and allowing them to feel at ease. That's when the questions will come, or that's when the conversation about hospital will come, rather than you bringing it up at a time when they don't want to talk about it. By giving them that safe space, you'd be very surprised as to what comes out. So play is the key to that. So there's a lovely quote there with all of it, helping them navigate the world. It's all kind of the same thing, but at the end of the day, all I want to get across is the power of play and what it does for children. So I suppose my role as a hospital play specialist is to embrace the value of play as a healing modality. And that's what it is, exactly, a healing modality. So it enhances the growth, development, and emotional and social well-being of children. So that's my whole job in the hospital, is the child's social and emotional well-being. So the physical side of things will be with the medical team. That will be all around their health and their medicines. Mine is massively around the emotional and social piece, and supporting everyone around that child to enhance their skills so that they are meeting the need of that child. So I work as part of a healthcare team, providing sick children and their families with supports for normal play and therapeutic play. It's a bit of everything. Procedural, I'll go through some of those in a moment. But I also work independently. But when I say work independently, I don't really work independently, because I'm always working with the parent and the child. Like the child is at the centre and the parent, and then we have that wider team, everyone down to the people that come in and hand out the food or change the bins. They're also a very valuable part of a child's experience. I know that the lady that hands out the dinners and Puffin is best of friends with some of our kids. Their favourite person when they come is the lady who hands out their dinners. So that interactions piece is so important. So I suppose the benefits of playing hospital, improving rapport and building trust is the biggest thing. And I think you kind of mentioned that as well, Emma, in your thing about Harrison. That like rapport is really important. Harrison doesn't want to make friends with people. He just wants to get it done with. He has this rapport with his mom. He knows mom can do it, and that's enough for him. But in other cases, there are children who actually really need to trust us and like us, and they do want us to engage. But for Harrison, he'll like you more if you don't talk to him and you talk to mom and you just get it done. Whereas Blake sounds like the little kid who wants you to make rapport, wants to like ask loads of questions, get involved. And that's very important, that we respect both of those things. Providing with a sense of control and autonomy. Distraction is a word now that I use kind of carefully. So if I'm doing something with the child, let's say we're putting in a Freddy line in their arm, and I'm using distraction as a technique without having explained that to the child, that can actually heighten a child's fear. Because if you're trying to get a child to say, look at an iPad or play with a fidget toy, or, you know, copy a game that you're doing, and they're already trying to focus on what the nurse or doctor is doing, that can be very anxiety inducing for a child, because they've too much going on. There's too much visual stimulation. There's too much input. They kind of feel like you're probably trying to trick them into doing something so that their nurse or doctor can do something without them realizing. So I always name that with children, and I ask them, I'm like, do you think we need to play while we're doing that? Or do you think you just want to watch? And that can change in the moment. And I name that in the moment for them as well. So I suppose for parents, you really know your child and you could see the change in them. And that's when you name that for them, because they might have decided that they want distraction, but actually in the moment you see they keep watching the nurse and they can't, you know, play with the item that they had agreed that they were going to play with. But you name that, you'd be like, oh, buddy, I see you keep watching the nurse. Do you think we just watch first and then we can do our game when we're finished? And it's giving back that sense of control, because a lot of children, when I ask them that question, go, I don't know. And I was like, that's okay. You don't have to know. We'll figure it out as we go along. So that's a really important thing for the child. hospitals making them fun and less frightening, reducing anxiety, building resilience. These are all the beautiful benefits of play. I'm going to leave them there. You've probably read them as I'm nattering on here, but I'm going to move on to more of the types of play, and then I'm going to go into some of the procedural work. So I gave you just a quick thing on the types of play because I want to, I suppose, acknowledge there are so many types of play. So there's normal play, developmental play. So I know Emma mentioned there that when Harrison was a baby, don't think there was any play supports for him in the hospitals, because play supports, I suppose, is being given procedural work and for older kids. But actually there's a really, really important role for the developmental play for babies that are in hospital. And I suppose that's possibly even another webinar in relation to supports for the younger cohort of children. Both the developmental piece and how we can ensure that children are still having that childhood if they have a highly medicalized life. Therapeutic play, so that's very purposeful play that's led a lot of the time by a play specialist with the aim of supporting the child's emotional and social well-being. Preparation play, I suppose that's probably a key to what a lot of parents want from tonight, is like, how do I prepare my child? How do I deal with procedures? So again, we will touch on all of those. Distraction play, not so sure I like the word distraction, but again, you know, it's maybe around focusing our attentions on something nicer instead of even the word distraction. Post-procedural play, that's another really important piece, and I suppose I'll touch on that a little bit later as to some of the tips around that. Sometimes we feel like, oh, we need to get them all the medical kits and we need to bring this all home, and they need to have like dolls' houses and ambulances that have all this stuff. And actually, yes, having exposure to that and having the opportunity to use it is great, but the pressure shouldn't be on for that type of play. Child mightn't be ready to process it at that time. They mightn't be ready to engage with that at the moment. And rehabilitation play then, so supporting children who've possibly lost some of their skills and they're trying to regain them. True fun. Like, I have so many children. I only had a little boy in Puffin the other day who wasn't back walking, a little toddler who just wanted to be in his mommy's arms. He was afraid to walk because of the pain before the surgery. Everything was sorted afterwards, and he was afraid to walk. But with bubbles and with games and with ball, he was at the end running up and down the corridors with us. But again, wasn't able to go there at the start, afraid, you know, clinging to mommy, not even wanting to let go, wouldn't even stand for us to start. But through play and interactions, we got this little boy back to realizing, actually, I can run and kick that ball. So normal play, I suppose when you're in hospital, sometimes we kind of forget the importance of play, and we're obviously focusing on our child's health and getting them back to health and getting them home and getting through all these procedures. But normal play is so, so important for children to be able to engage and play while they're at the hospital. So some of our hospitals have wards that do have playrooms. And we have the beautiful play volunteers coming in that bring in resources to children and play with children on the ward. But even having those little bits from home, like the things that they like to play with. Now, also going to hospital can be very expensive because you end up buying new things as you go on, and that can be really expensive for parents. So the little bits that they have at home, having a little bag packed, we'll talk about that later, so that we do have normal play opportunities, because it does all those beautiful things like reducing stress, creates a sense of familiarity, which is the main thing. Like, kids play all day. That's their language. That's what they do. And not having exposure to that is very unsettling, especially being in a medical environment with lots going on. So I use play and play observations to support children, and to kind of, I suppose, weave a path for what's actually needed to support them in their stay or towards a procedure. But you as parents are the key to this, and you know your child best. As Emma said, like, inside out, she knows Blake is totally different to Harrison, and she has to totally change it up as a mammy when she's in hospital with one child versus another. So these are some of my favorite toys to go to for certain age groups. So like when I do, say, burns dressing clinics would be one that I would do. And a lot of the time children who would have burned dressings would be younger children because they've pulled a cup of tea on themselves, or they've put the hand on the stove, or those kind of accidents that happen when they're kind of at the toddler age, once they're starting to crawl and move. So wooden blocks, this spinner toy where you put it on, it spins down, cause and effect toys. So this lovely little shape sorter makes a noise when it goes down. Bubble machines are great if you can get a good one. And that little piggy one that sings and wobbles, like children love, and especially the younger children, the putting in and the repetitive play of putting it in, taking it out. But like a toddler could play with this one pig toy for 2-3 hours and not get bored. But having those little toys that you know are going to be interesting and exciting to a child, cause and effect is great. These magnetiles and magniformers are my go-to for children that like any form of construction. Even as fidget toys for older children, they can be great. I actually have a trunky full of fidget toys that I bring. So one of those like kids trolleys that a lot of people use for holidays and the kid can sit on it and pull it along. I have 2 or 3 of those. I've one on every ward full of fidget toys. So things like the magnets, Play-Dohs, kinetic sands, paints, Lego kits are great for kids who like that and they can take up more time. So again, even just buying, like the kits can be expensive, but having like a Lego kit where they can get creative and make bits themselves. These are some of the games that are quite popular. Things like the Pop-Up Pirate and the Crocodile one are really good for children in relation to I suppose, the animation and effect. I don't know, do they enjoy the toy or do they enjoy my massive, dramatic Hollywood presentation on, oh my goodness, when it pops. But it brings such a level of fun. So I had a little girl in who was getting burns dressing done. Again, when the burns dressings are done, there's a special dressing that's put on, but it can get dried to the actual burn when it's healing, which is, it's meant to, but it's very hard to get it off without wetting it. So it can be a long enough process to dampen it and allow the child time to actually get it off. So this little girl was finding this really, really difficult. It was bawling crying when I arrived because she didn't want anybody to touch the burn. But again, through explaining that to her, first of all, I had to actually help her regulate her breathing because she couldn't even talk to me. She was crying so much when I arrived. But by the end of it, this little girl was loving having this crocodile. Well, actually, it was a hippo I have a hippo version as well. This hippo and this Pop-Up Pirate. We were playing games. She was in total control as to who was next. So daddy was next, I was next, mom was next. So giving her back all this autonomy and control in it. After she had her bandages done, because she was firefighting with the bandages, we left her do all the water. We left her do the wipes. So it was giving back all that control. And then we had these beautiful toys. And the only thing that was bothering her while she was doing it was, but if I do this, can I play with Rachel next? I was like, yes, Rachel will stay and play when you're finished. So we had these toys, and it was the cause and effect piece where it was like, oh, big dramatic, that she was loving so much. So any of the toys, but your children, some of our children prefer, the quizzes or to talk about things. They're more into the intellectual side of it, things. Some children love the iPad or their phone. I'm not big on screen time, but when it comes to hospital, there's another side to me when it comes to the hospital. And if a child is looking at their iPad and a medical professional comes, what happens a lot of the time is parents will say, oh, put that away now and talk to the lady. And I'll actually say, can I have a look at what you're looking at? I'd like to join in because I don't want you pausing it and then them going, oh my God, I was doing this. I was trying to stay happy. And now I've been stopped doing my favorite thing. So they go into this little spiral themselves. So again, like if the doctor is talking, you can say to the doctor, oh, we'll call him Jack. Jack is just going to continue to look at his iPad for the moment. And if we've any questions at the end, we can ask Jack then. But Jack is still listening. It's not that he's not listening to what's being said. He is listening. He can hear. But he may just need to focus on his iPad to be able to cope in that situation. So I'm all for the iPad in that moment. So the therapeutic side, I'm going to jump back to the therapeutic. Everyone talks about the therapeutic play and what we can be doing. So this is my real purposeful play. And I suppose therapeutic play and play therapy are 2 different things. So a lot of people call me a play therapist in the hospital. I'm not a play therapist. Now, some of the play specialists on the team in Ireland are trained as play therapists, but they're not doing play therapy when they're working with children. They're doing therapeutic play. So there's a big difference in that. It's like one piece of work and I might never see a child again, or I might see a child over a period of time, but it's very kind of ad hoc. It might be in clinic, but then I mightn't see them the next visit because they come to A&E on a Saturday night and I'm not on duty. It's very different to the relationship that you would have with a play therapist. So I suppose when children are in hospital with me, I try to do therapeutic play piece in advance of procedures, after procedures. It just really depends. It's all very individualized. No 2 moments in my day are the same, never mind 2 hours in my day. So with different children, I'm taking different approaches. And now some children will be linked in with a play therapist. But in the hospital, play therapy is not what is happening when you meet a play specialist. So when you look at the picture here of the dialogue, you can see that play work, then therapeutic play, and then it would be play therapy, and then on to child psychotherapy, psychology, etc. So that's where it kind of lies in between. So the distraction, as I said, so some of the techniques that might help you and help your children. Breath work. Now, some children get allergic to breath work. So again, it's around the fact that a lot of the time we don't introduce the breath work until we're in a situation where we really don't want to listen to the idea of counting our breaths or doing breath work. Breath work needs to happen in situations where the child is comfortable and safe at home, in preschool, in their schools, on the soccer pitch before they take a penalty. That's when they need to practice their breath work. Because if we're only focusing on breathing techniques when we're about to put a needle or a Freddy into their arm, they're already probably in a heightened amygdala response where they're already frightened, they're already worried, their heart rate's probably already racing, and their breathing is starting to get faster. So what we need to look at is actually doing breathwork techniques through stories, through play, through interactions, through modeling. So I had a conversation today with one of my parents around modeling that at home. So that thing of doing your breaths yourself. But like, God, I was having a very stressful day at work today, and I decided I'd start using my breaths to help me to stay calm because I was getting very stressed. And you might be saying this to like the other child, or you might be saying it to your husband or wife or whoever. It doesn't have to be to the child, but it's that modeling of the behavior of learning to use your breath in situations when your emotions get high. And that's when children can then relate to it. So children I've worked with previously, a little girl came in to get her bloods, and she had her bloods done in 2023 with me. She came in yesterday to get her bloods done again. And when I was talking to her in the room, she started practicing her breath because she knew straight away, because I was like, there's little things that we can do. Can you remember any of them? And immediately she started taking a big inhale and exhale through her mouth. I was like, you remembered. So again, it's just making that a skill that they have outside of the hospital so that they can bring it in their toolkit prepared. Counting items that you can see, hear, touch, bringing in the senses, very powerful. There's one little book that I use that talks about find 5 things that you see that are blue. These little things, and you'll know what works for your child. Some children will be like, oh, go away, I'm not doing that. And other children will love it. So again, it's allowing the child to decide that and have that idea. So I have the beautiful thing of being able to say, well, some of my friends like this, some of my friends like that. What about you? What do you think? Kids will come up with really cool things themselves. Some love singing, some hate singing. Cause and effect toys can be great. Fidget toys, music toys, whatever works for your child. Now, again, I would say a lot of the time, my toolkit of toys isn't my best asset. My best asset is my voice and my interactions. So my tone of voice, my nonverbal behavior, and how I'm communicating with them. That is the key to it, because what my goal is to make the child feel safe and to trust. They're the 2 biggest things, but there's all these beautiful distraction toys, as they call them, available that you can use as well. So these are some of my lovely ones that I add to my little trunkies, and thankfully you can find them cheaper in like pop-up pennies and Euro Giants and those kind of ones now. They were very expensive to start, but they are getting cheaper. But also kids can make their own ones. Like I actually find the blue gloves that you find in the hospital, if you make a balloon out of them, it's a great squeezy toy. Like I'm conscious of we don't want to be spending loads of money. So there's loads of little bits that you can actually just get creative on. Children absolutely love a blow up balloon, which is a glove. It's the easy, simple things. So I'm going to bring you to the preparation piece, I suppose the piece that you're all probably holding on going, Rachel, will you just get to the point? Medical procedures and where we need to go. So explaining the procedure, clear, developmentally appropriate terms. Very important not to leave out details. Very important not to lie in this. So some people are like, well, I'm not going to tell them that. He's going to freak out. And I'm going, but we need to be honest and tell him in advance so he's prepared. If we don't tell him and it happens in the time, that's when he's going to go straight to a massive fear response and it'll be hard to pull him back. So we need to look at actually giving him the facts in an age-appropriate way, what's suited to their age and stage of development. So it isn't always about their age. So sometimes people will be like, oh, he's a fine, tall, strapping boy. But I was like, but actually developmentally, he's not at a 15-year-old level. We need to look at what his developmental needs are and his strengths and interests. They're my key for any kid. Every child is at a different level. Every child has different strengths and interests. That's what I'm working with. So the softest kind of language you can have. So when we're talking about bloods, I don't talk about the pinch, the prick, the stab. I had one little boy who's like, they're going to stab me. And I went, whoa, stab you? I was like, no, they're not. We don't do any stabbing. Stabbings are used with knives in video games. That's not okay. I was like, what we do with our butterfly, I don't call the needle a needle, because again, the word needle is enough to trigger a fear response. I will call the one with the blue one a butterfly, or the yellow cannula ones I will call a bumblebee. Or I'll ask the children what they want to call them. So some of them will call them like sunshine because it's yellow. But kids will come up with their own little names for them. So rather than saying even the word needle, and I say that to children, I'm like, bet you if I say the word needle, your fear starts to get big. And they're like, yeah. I was like, well, we won't call it a needle. We'll call it a butterfly, or we'll call it a bumblebee, or we'll call it, Iron Man or Captain America, or whatever they want to call it. But we use least threatening language, and we're always very honest. We try to say what to do instead of what not to do. So if I say to a child, don't move, the last word that they hear is move. Whereas if I say we're going to do frozen statues, they hear frozen statues, or they hear we're going to be super still. That's what we want them to hear. So in moments when children are heightened, they're not processing at the same level they could process when they're out and about playing with you at home. So when they're in a hospital, they're already heightened. So their ability to hear you and to process the language you're giving is different. So we need to be giving them minimal amount of the language and to the point. So I need to say, we're going to stay super still, rather than saying, don't move, because don't move, all they hear is move. And the focus is on move. So individualizing the way you express the information, depending on their age, their temperament, their developmental level, their emotions, and their physical state. Like, we have to take in so many factors. Like, I work with children and I might see them for, like, I've been working 5 years here, so I might know them the full 5 years I've been here. But every time I meet them, they're in a different place, and I have to judge where they're at and what I need to say in that moment. So I'm always figuring that out as I go, because I might have done a lot of work with a child on this, but they come in and they're totally dysregulated. They're really upset. And whoa, I have to peel that all back, and I have to start back at square one, and I have to do the emotions and the validation piece before I go any further with them. Keeping it honest, what needs to be done, why it needs to be done can be very important. I had the ED staff call me down to a boy one day. He would not even leave the doctors past the curtain, wouldn't leave them in. And like, the doctor even had his arms behind him. He's like, my arms are behind me. He was like, no, he'd scream the building down the minute they would try to get through the curtains. So I came down, and the big thing with him, it wasn't actually the needle, it was the wipe. He did not want the wipe, and he'd had it before, and he didn't want the wipe. And again, I explained to him why he needed the wipe. The wipe had to happen because otherwise there's germs on your skin that could go into your blood. That's dangerous. Once I had explained that to him, we had no problems. He went ahead and was watching and took no notice. But it was the why that got him over that hump. Whereas the doctors are like, oh my God, he must be petrified of needles or whatever. It was like, he did not want that wipe. He did not like the smell. He did not like the cold texture, and he did not want it. But once I explained to this little boy, he was only 4, explained to him, there was no problem, because he recognized that actually I don't want to get sick, and yes, I need to get this fixed. But also that child's trust had been broken, because adults who had been with him, his aunties and things had been with him, they had actually lied to him. And that was his big thing. And he told me all this as we were playing, as the session went on. He was like, but they didn't tell me the truth. And they told me this and they told me that. And I was like, oh, buddy, that's really hard. And I was like, I think, your auntie was saying that because she didn't want to make you worried. But really, it's important that us adults tell you the truth, because that helps to bring down your worry when you know the truth. So giving choice is another big, massive thing. So I gave him a choice of, did he want this wipe or that wipe? With 2 different wipes. They were exactly the same wipe, and what they did was the same, but the packaging looked slightly different. But again, the fact that I gave him a choice of which wipe was him feeling like he was in control of something. So I said to him, I cannot give you a choice about the wipe happening or not happening. That has to happen. That's not one choice. But our choice is, do you want the blue one or do you want the yellow one? And he chose whichever color. Plan your distraction. As I said, distraction is important, but it needs to be planned with the child, and giving them a job. Sometimes they do enjoy that. But again, some children don't. Some children, like Harrison. Harrison just wants you to hold him. His fear gets too big. My little girl who came in yesterday that I mentioned earlier, she came in to get her bloods done, and she could name it that, like, her warrior was getting too frightened. So I will talk about the warrior brain in a moment, but that's her fear brain, and her fear was getting too big, and she was naming that, and she was like, this is too hard for me. And I was like, that's okay. We've got you. If your warrior brain is going to get too big on this, and when it comes to it, I know what warrior is going to say. Warrior brain is going to make you say, stop, 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 don't. Can you tell me now, when you've got your thinking brain on, are we allowed to ignore your warrior brain when he says stop? And she says, yeah, because he's going to keep telling you to stop. And I said, yeah, I know he is. And even though you're doing your breathing work and you've got this, and you're trying so hard to keep him at bay, he's still a little bit worried. So what we're going to do is, our thinking brain is here now. You're telling me that when Warrior says stop, 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 we're not going to stop. We're going to continue going. You and I are going to do our breathing. You and I are going to do our puzzles. I was putting like a pop-it puzzle together. We're going to do that. But I had permission from her to do that. So this is the important thing. The permission piece is there. And as Harrison's mom has said, Harrison has given mom permission to do that. That's what he feels is best for him in this moment. And that's what we have to respect. Medical kits. So when we talk about play, we see all these lovely doctor kits, these plastic ones. Oh, they bother me. So they look nothing like what a doctor uses in the hospital. It looks nothing like what your GP will use if you go to them. So having real medical equipment is what's needed. Obviously, safety-wise, some things we can't have openly access to a child, but if we're with them and supervising, yes, we can. But it would be real bandages, real thermometers, real plasters, real glucometers. They need to see the real thing, because children will turn around to me and go, that doesn't look anything like what the doctor uses. And I'm like, yeah, I know it doesn't. That stethoscope looks nothing like what we have in the doctors. And for children, some children are very particular, and that's the thing that will bother them. They'll be like, you told me it looks like this and it doesn't. And they have to have it correct, especially if their fear is quite heightened. So trying to have the real medical kit. My first aid bag is my medical kit. I have the real one. I have one here behind me, a little one that I have, but it has all the real items in it. So I have real Freddies in it. I have real bandages. I have my proper freeze sprays in it. Everything that's in it, proper syringes that are from. And again, I often ask the GPs and stuff that if things are out of date, can I have them? So it isn't that you have to go out buying all these things. You can use all of them. And for children, having the real thing is so important for them, because when they go to hospital, then they're like, oh, I know what that is. I play with that at home. I have that in my kit when I'm playing with Dolly or Teddy or whoever. Visuals are really important. So, and again, it's the real stuff I show them. I show them the real needle. I take out the needle, and parents are like, oh, don't take out the needle. Oh my God, they're going to get so scared. I'm like, that is what goes into their arm. They need to see it in a space where they feel safe and they know I'm not using it. This is just me showing them. So again, lots of GPs are really good to help with this. So even if you're going in for, let's say, another appointment and you need an antibiotic for a chest infection, and you'd be like, oh, can you just please show us this, this, and this? And it's really, really helpful for the GPs to actually show them in those situations, because it's not that they need it right now, but this is what we would use. Again, I think I nearly need to do little workshops on that for children. And that is something that I'm looking at for here in CUH, is that for children who are coming for their bloods, is that I would do like a little phlebotomy workshop that they would come in and they would get to see these. And we do it on the teddy bears. I put more Freddies into teddy bears and dolls and Pokemon, Barbie dolls. Barbie's quite a difficult one. Her arms are very small. But I did one on a Barbie now yesterday. So it's very important that the kids get to see the real deal. And a lot of the time they enjoy their teddy or their favorite thing having a Freddy line or needles and bits and pieces. Other times that really distresses them. They do not want their favorite teddy to have that. A lot of the time I'll present them with a new teddy bear for that. Teddy also has the same burns as yours. Teddy needs his Freddy in his arm as well, because he needs his medicine just like you. And you will find that children really respond well to that in some cases, and other children are like, no, thank you. I don't want it. Don't want to see it. And we have to respect that, because that's where they're at in that moment. Visuals then for the cannula, just slightly different. Again, I would use the real pictures of the freeze sprays. A lot of the time, some children don't like the sensation of the freeze spray. So freeze sprays and numbing creams can be used for some of these procedures, but it's important that that's asked of the child. Do you want it? So that little girl yesterday did not want the freeze spray. She did not want the cream. That was fine. And again, it's that choice. Do you want that? Do you like that? Will we practice on your hand first? See, do you like it? And you can ask the phlebotomist or the doctors that, sorry, can we just test that first and see what it feels like in our hand? And we'll see then if we want it for our jobs. So catheter changes, I would do a lot of the work with that with children, step by step. So with the visuals, you know your child. So you can take pictures of the steps and things that need to happen. Google can be great. Link in with some of your pediatric team if there's a play specialist involved in your hospital. At any point, if there's anyone in CUH and you want me to try and get visuals for you, that's no problem. Just ring the word and I'll give you those pieces, because it's really important that children have them. So this is just a simple one that I did up for a little boy, keeping the language quite simple for him because of his age. So syringe on tubey, he calls his catheter a tubey. Old tubey comes out, we wipe, jelly on the belly, new tubey, count to 5, syringe, finished. So I take these off as they're happening while we're doing them. And this is something that we've been progressing with. This boy was finding this a really difficult procedure. And over time, we've been putting in these little strategies that help. And then we do our play session before and after. And he is really, really improving with this. And he's able to talk to us and tell us things before. He wouldn't even talk to the nurse who does this for him. And now he's given her high fives and going, I'm so happy, well done. And he told her there recently, I think it was the second last appointment, good job. Because when she was finished, he said to her, good job. So he's gotten to this point, whereas before it was at a point where we were having to hold him. He was getting quite distressed. But again, that's always named with him. So when it comes to a point, there are points when you're in a medical procedure, it's an emergency, you need to get this done. You don't have the time to talk to the child that needs to talk. So like in Blake's case, she likes you to talk and explain. Sometimes we don't always have that. But what we do have is the ability to say, this is really hard. I see it's really hard for you. We need to get it done really fast. I'm sorry it has to be done this way. But where possible, we work through it and we don't hold in any way, because that can be really difficult for a child moving forward. But Harrison then says he wants that. So Emma's little boy says that that's what he wants. And there's a big difference between him having told us that and us holding him without having his permission or without explaining why. This is the little puppet that we use. So I use puppets and teddies all the time. This is actually a specific one that has a pubic catheter in it. So we can do the play with that for the children. There's loads of now medical dollies and stuff, but I make up my own ones. Like I put nasogastral tubes into, I did one last week with Spider-Man Squishmallow. He got an NG tube put in because my little boy was going to Dublin to get his NG tube put in. So we put it into Spidey before we left. He knew all that was happening. He was very excited when he came out to tell the nurses, and he hadn't been speaking to the nurses. So this is a boy who is going through chemotherapy, and he came back out and he's not really talking to the nurses because he's not well and he's sick of being in hospital. He's sick of treatment. And he came out and he was all excited to tell them. I turned around, I was like, are you going to tell them the news? And he was like, yeah. He's like, I'm getting the same as Spidey tomorrow. And they were like, what? You're getting the same as Spidey? He's like, yeah, I'm getting the tubie in my nose. And he wanted to call it a nose Freddy. So he's used to Freddy's, but he wanted to call his NG tube a nose Freddy. So I have another boy who calls any of his lines, he has a line here that he calls Iron Man, and then if he gets a Freddy, it's usually a Spidey Freddy is what he wants to call it. But that kind of takes the medical piece out of it, and it makes it more fun. It makes it more playful. It brings it back to, and again, it's simple things like that, like, telling your doctors, well, actually, this is Iron Man, or, this is Spidey. The MRIs, I do an awful lot of work with the MRIs, and we have had massive success. I think it was like 93% success rate was one of the rates. Now it has gone down to, I think it's 89 now, because I'm working with more children with more complex care needs who would be needing a GA or needing sedation. But as parents, for the MRI, I suppose sometimes we have had our own MRIs and we're already going, oh my God, he'll never do that. He'll never sit still. He won't manage the tunnel. Oh my God, like there's no way. The noises are so loud. And we ourselves are gone into our own spiral on our experience. Whereas when you pull that all back, it is a very different experience for a child. So this lovely tunnel that you see, that was made by a parent of a boy that I did MRI prep work with. So I did prep work with him. The little boy aced his MRI. He was fantastic. He was so proud of himself. And his dad was an engineer, and he came up to me after. He's like, do you think it would be helpful if I made like kind of like a pretend one? He's like, I could make, and he'd all this design. He was obviously creating all this in his head, and he created this for us. So I can pretend that this is the MRI scanner. I can do it on the bed with the child. We can go through all the steps. And then I have a story that I give to the children. And when you can prepare them, what I talk to them about is we've got to train our brain, train our ears for listening to all those noises. And then we have a plan as to when we're lying in there, are we thinking about our soccer matches? Are we thinking about a movie? Are we thinking about our holidays? Are we like pretending that the noises are whatever it is? Like one of my boys loved Minecraft, and he was saying that like some of the noises were the shooting and the bits and pieces that were going on, like the hacking for the hammers and stuff was the bang, 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 bang. And then the knock, 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 knock. It's making it fun and playful. And when you can do that, children, they just like, they're surprising everyone. It's the MRI team calling me the magician, and I'm like, I'm not a magician. Like everyone in the MRI team gets so excited when they see me coming because it's the fun and play factor that's coming. And I just came out of MRI today with a beautiful girl of 13 who she's had 3 MRIs previously under sedation and when she was younger and stuff, but sedation's not going to work for her anymore. She's older, and she was very, very nervous. But she aced her MRI with support because we trained her ears. We told her all the steps that were happening. She brought in her own loops for her ears that are more comfortable than the orange ones that keep falling out. All these small little things that we had planned. I was going to go with her. Her favorite teddies were coming. Mom was going to hold her hand. I was going to do the countdowns. Some kids like to know how many sequences. Some kids don't. Having this all in plan is fantastic, and parents are actually blown away at how good kids get on. I had one parent rang me the day after. I didn't even go down with that child that day because I was actually off the day the child ended up going for MRI, but I had done the preparation. She rang me and said, "Oh my God, I can't believe he did it." She's like, "You believed in him when I didn't." And I was like, "The only reason you didn't believe in him was because, it's a big machine, it's loud, it's scary. You didn't think that it would be something he could do." But when we bring it playful, I often talk to the children about, "Oh my God, you can do statues." Like, adults aren't very good at musical statues. Children are way better. So you can stay still way better than an adult. Tunnels, you always go on tunnel slides. You go in the tunnels in the playground. Like, children love tunnels. So you talk about the tunnels and being in the tunnels. You talk about the noise. You'd be like, "Come here, your ear." And some children are really sensitive to noise. And if they are, I acknowledge that. And I say, "That's hard because your ears hear noises much louder. But we're going to do everything we can. We're going to put in our earpods. We're going to put on our headphones. We're going to think of other things. Maybe we could think what the noises sound like." And again, we'll train our ears. Maybe we might start training our ears at home at a low volume. You play it in the background while we're playing with our favorite toys. Again, children come up with the most beautiful ideas. And I had one boy in particular who was very, very sensitive to noise. Like, literally, when I put on the MRI scanner, he was bopping. When I put on the sound, he was like jumping when the new ones would come, because some of them are very sharp and they come out of nowhere. And it goes from being tick, 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 beep, really, really loud. And he was jumping with them. But we did that piece where at home, when he was playing, and he loved Lego, when he was doing his Lego, he was playing it in the background. And he was so proud when he came in for his MRI. He said, "I've trained my ears. They're ready for today." And I was like, "Really? Are your ears all trained and ready?" And he was delighted with himself. And he aced it because he had trained his ears on it. So children can do really, really well. And again, kids will often say to me, "But I don't believe I can do it." And I said, "Well, I believe you can do it. So sometimes you might need to borrow my belief, but you definitely can. I know you can. I know you're good at this. You've done your statues, you've done your noises, and staying still will be easy for you because you do statues all the time." And we actually have a lovely helmet that helps us to stay still. So for kids, it's much easier when you have these lovely positive vibes to it, rather than that. Like, parents have often said in front of a child, "Oh God, I had one of those, I hated it." And it's a slip of the tongue. You don't mean to say it in the moment, but then the child is like, "Oh," and I'd be like, "Oh, Daddy, that's because you didn't train your ears." Like, if you trained your ears, Daddy, it would have been much better. Was it the noises you didn't like? And then he'd be like, "Yeah." And I'm like, "Oh yeah." And then I was like, "But I bet you also don't go through the slides and the tunnels when you're at the playground, Daddy, do you?" And he's like, "No." And I was like, "But Jack does. Jack knows that." So what you're doing is you're just reframing it and putting it in a positive light. So for children, that's what we need to be doing for things like MRIs, X-rays. Again, an X-ray doesn't even touch you. You're just standing there, but it's preparing them for that. CHI have developed loads of new stories. So again, some of them are specific to visiting different parts of CHI. So it's Connolly, Crumlin, Tala. Some of them are just generic, but they're a lovely website to go to. Again, even if you, like, we have so many technologies now these days that even if you just put it into Google, you'll probably come up with great ones. Some of the American hospitals are fabulous ones. So the Boston Hospital, the Philadelphia Hospital, they have beautiful videos and stories. But thankfully, we have Irish resources that are coming. So you can log on to those, and they're just simple stories. So these are just a couple of screenshots from it. So the Freddy is a tiny plastic straw that goes into my vein. It will allow blood to come out so that I can be tested. Then I can have some numbing cream or cold spray put onto my skin to help with the pinch. And then a sticker is placed over the numbing cream so it can work. It is important that I leave the sticker on for 30 minutes. So the story is like literally picture and a little bit underneath it explaining. And it's all the real pictures of the real things. And that's what most children respond best to, because these pictures and now some of my children prefer the cartoons. I often do up like Peppa Pig versions or Paw Patrol or Pokemon or dinosaurs. So dinosaurs going for his bloods. And I'll make that up myself with the information based on what my child is interested in. So some kids have, really big interests in, say, Pokemon, and they don't want talk about anything else. So I'm going to do a Pokemon visual. Also, some children don't like to talk about themselves. They don't want it to be a story about, "I'm going to get my bloods done." It's a bit like, oh, it's too close to home. So if you can say, Pippa is going to get her bloods done, or his favorite teddy bear is going to get his bloods done. But again, I'd only do their favorite teddy bears if they've given permission, because sometimes that can absolutely upset them, where they're like, "No, Teddy's not getting it." And I'm like, "Okay, that's fine. Will we get a new Teddy, or who will we pick?" This is a little story about going for surgery. So there's lots of nice resources, and there's loads out there. But this is one of the ones that was written by Dr. Anne Marie Crowe. It's about going for surgery. It has all the little steps. again, there's a little video of it online. A lot of these are free resources, which is what I like. Don't like to be putting extra expenses on families. So these are free resources. You can get the video online. It comes up if you just put in the title and the author. Hey Warrior is another book that can be downloaded or bought. It's an Australian author. They do Hey Warrior and Hey Awesome. This is what I talk about, the warrior brain. So I talk to children about their warrior brain and what their warrior is doing. That's making them scared. This is a lovely one. Now, the only thing about this book is it talks about the word anxiety. I'm quite slow with the word anxiety because I think as a nation, we're kind of moving towards that. I am anxious, my child is anxious. And what I prefer to focus on, and I'll talk about language again in a minute, is the thing of I am feeling anxious at the moment. If I am anxious, I'm owning it. It's part of me. It's my identity. I am it. No, I'm not. I am a person who feels anxious at a point in time, and that will change. So I suppose that's a really important message. So now it is a beautiful book, and it does talk about anxiety. It's probably for like maybe the older kids, like maybe 7, 8 plus. The other one I would use would be the My Big Feelings Come and Go. This is a nice one for, say, the younger kids. There's lots of bright visuals in it. And it has lovely little things where it talks about curling your toes to relax, doing your breath, looking at things that are blue, find 5 things that are blue. So again, it teaches children about the fight, flight, freeze. So what happens, and I suppose that's one of the most really empowering things for children when I work with them, and what I see, and that's my biggest tool, is helping them understand what's happening in their body. So as parents, being able to support a child to name that and learn about that before it happens. So this is why lovely stories like this, and again, sharing this with schools and sharing this with preschools, so it's not something that you're consciously doing at home, because sometimes kids are like, oh, mom is off on it again, or dad is doing that again, oh my God. And they're very aware that you're doing this in preparation for hospital. So trying to normalize it as much as possible is great, because kids then don't feel like it's a targeted thing for them. And these are beautiful stories that you can adapt. Again, I've shared them with a parent today, but I've actually said to her, they can be quite lengthy. Maybe print them off and take out some of the pages, or maybe just adapt some of it. I like to make my own stories for children based on what's happening for them and what they like. So as much as I would say, yeah, there's lovely resources out there, I prefer to tailor things. And in my work, I would use tailored ones a lot more. But you know your child, you may not be too interested in having, but actually children love making them themselves. I get children involved in making up their own little books, and that can be part of the process and part of the project. But again, I don't want that to be something that you've put in, oh, that's a great idea, and we're clinging onto it as adults going, oh yeah, we'll do that, but actually your child doesn't want to. So this is very much so based on your child and how they respond to it. I suppose that's my biggest thing when I talk about any of this work. It is individualized. It is different in every second, every moment. One visit to the hospital is never the same as a second, even if you've all the same staff and you're doing the same procedure. It's never the same. There's too many internal and external factors that are changing. Breath work, again, I talk about this. The star one is a lovely one, starfish one. And again, you can do the figure of 8 one, or you could do the finger one where you breathe in as you go up, breathe out, breathe in, breathe out. I do this with some of my kids love cars. So their cars will roll up and roll down. They might like a Pippa Pig figure. So Pippa goes up and down. Like, again, whatever your child likes, that's what we're doing. And it might be that like the mega doodle boards, like we'll draw our things up and down as we're breathing. We're going to go up and down. Whatever your child likes, you bring that in. It might be the slinky. So the slinky goes up and the slinky goes down. It might be those tubies that make noise that you pull out. We're going to pull them out as we breathe in and breathe out. Breathe in, breathe out. So it's really trying to find what your child likes, because breath work can be. So I have a child in the moment who's on the wards at the moment with me, and they've been talking to the psychologist about breath work to help with this. And actually I went in and they were like, I can't do it. It makes it worse. And I can't get and he's actually gone into a panic about the breath work. And I'm like, oh, don't worry about that. We can do it differently. Let's look at what you do like to do. You like to do slimes. You like to do messy play. How about we do our breathing with that? We get our squishies, and when we're breathing in and out, we just do it like that. We don't have to count. We don't have to focus on our breath. We're just going to do our slime, and that's going to be easy. And it is, and it's working great for him. So that small change has him now doing his breath work and him feeling confident about it, because that's what worked for him. Post-procedural play.
Rachel, can I come in, please?
You can. Who's talking to me now?
Sorry, it's Bess. There's a question here coming in. Suggestions for a 6-year-old autistic boy with developmental delay who has had a huge amount of orthopedic surgery and intervention in the past 3 years. Trust is completely gone and more surgeries coming up, and does not respond to books, videos or social stories in preparation. We are in crisis mode and can barely get him in the door. Do you want to respond to this now, or maybe at the end of the presentation?
So this little child is not in a place to actually do the prep work. And I was on to a parent today in a similar situation for her little girl, who the child just can't cope with any medical play at home, any social stories. She doesn't want them. They are actually stressing her out. And the parent is like, what do I do? And I said, we take it at her level. If stories in the home environment are too much, we don't do them. What we need to look at is the trust piece and trying to work on the rapport piece around that. So as your parent, like what I would be saying, I'm going to talk about documents now in a minute, that this is me documenting documents that you can do to support your child. Like, is your child at a point where they'll actually like engage with you? Are they speaking? Do they use verbal communication? Sorry.
Lisa saying he's verbal. If you want to unmute, Lisa, you're very welcome.
Yeah, so if he's verbal, and you can have these conversations in advance about what he wants people to know, but it may not be something that he's willing to engage in discussions with, and you need to judge that. You know your son, if he's not able to talk about going to the hospital and things, that's fine. But you could also frame this in a case of like a little project that we're doing for school. So my teachers want to know what helps me, what works for me. That might be something that you actually say to the teacher, that it might be something they do in school totally. So I had that conversation with that parent today, that actually this needs to be something that's not done at home with mom, because they almost know this is for hospital and they're already heightening, and they're like, Mom, stop asking me, and it becomes a chore. Whereas if it's something that's done by their school teachers and it's part of something that they do with all their friends, it's a very different thing. Or if it's information that you can kind of get in a playful way when you're playing, and be like, do you know what? I really like when I can play with my fidget toys. And when I was in the conference, so that it was very boring, I just sit for ages. I liked this. It helped me. Well, do it helps you? You can do it in a totally natural way with your child. Find out this information. Now, you probably know what works for your boy or girl. And you don't need to go any further. You can probably write a list a mile long. But they're the kind of things that you need to look at. How can we make the visit some way better? Can we link with anyone in the hospital in advance? Is there a play specialist we can link with? Can it be that we look at having the staff briefed on what works? Does he want them to talk to him? Does everything have to go through mom? Can conversations happen outside of the room? So I would have a lot of children where I will come in and I will do the play, and I'll ask any conversation that need to happen with the doctor to happen outside the door, because this kid does not need to be hearing all this extra verbal input and overthinking on that. They can't cope with any of that. I will also have children that just want to sit and play on their iPad and not engage with me at all, and that's perfectly fine. I will name that. Like, it's totally different in every child. So I suppose if you're at a point where you've tried some of those things, your child is already in a heightened response, we need to be looking at trying to do skills teaching and gathering of information prior to going in, so that we have all of that ready to share with the medical team and anyone else, and trying to make small adjustments at that visit as to what can be different, what can we plan differently. And it might be that you as the parent need to take control of a lot of that, because the child isn't able to give you their voice in that situation. Does that help in any way?
Yeah, I'm not sure if my mic is working, but yeah, that's perfect. Thank you so much. Thanks, Rachel.
No problem.
Thank you.
So what was I talking about here? Whoops, a daisy. Oh, I'm after giving you all of them. Hold on. So my whole message, play is not a luxury, it's a necessity. It's not a choice. It's crucial for our well-being for children in hospitals. And I suppose it's hard for parents to be playful when you're worried about your child and stress levels are high. But actually, my experience and what parents will tell me is that actually being playful has helped them massively, as well as their child, because being playful helps with all of the regulation of the nervous system for both mom, dad, guardians, whoever's involved, and your little boy or girl. So it is very important that we all go down that route, because if we're laughing and playing, there's lovely happy hormones being secreted that will really overpower and help all those fear responses that are happening, and all that extra amygdala responses that are going on in our little brains. So we do really need to help with the stress and anxiety by being playful. Now, it isn't always hard or easy to be playful, and some people aren't a playful person. Like I'm probably very irritating at times, but I can bring it totally down. There's very different sides to me. So Emma would have met me in the hospital. I have a very high, chirpy, happy, like almost annoying personality sometimes with children, where you're like, whoa, this one's like the Energizer Bunny on speed. But I also have a side to me where I can be really quiet, really calm, really silent, and I totally change depending on where a child is at. I'm not afraid to be silly. I march up and down the corridors down, we're going on a bear hunt, we're going to catch a big one. And I've doctors looking at me going, what is happening here? But I have a 2-year-old who has had extremely traumatic stuff happen in the 2 years of her life. And I am going to be making this playful and fun. This kid is laughing and I don't care. I'm going to be playful. And I'll include the doctors. And the doctors are all really used to me here. New doctors, because we would have new doctors in turnover. They're always told by the other doctors about me. So they've always heard about me before I ever meet them. Like, oh, we've heard all about you. Because CUH is very aware of this need for play. And we are trying to promote it much more. And we have a lot of turnover of doctors. So it's always important that we're getting that out there and that doctors are experiencing this and seeing this. So be silly, look silly. Don't be afraid to be dramatic on things. Kids really enjoy that. That's why they like me so much. I had a child coming back for her burns and her mother was like, she did nothing but talk about you all week, Rachel. Literally her school teacher, her parent, she actually brought her auntie this week because auntie had to meet me because I was her new best friend. So there was no talk about coming for the bandages and the scariness and the water and the fear. This was the kid that was bawling, crying in the bed when I came to her the first day. And she's like a new woman. She has like the confidence, the shoulders are back and she's telling the nurses what to do. And she's like, no, I'm going to do this part and then you can do that part. She's in total control of her care. And it's beautiful to see. So be silly, be playful, share what works for your child. Your child is different to every other child. We're all individuals. What works for me doesn't work for you. What works for me today might not work for me tomorrow. So that's another thing. Be open to changing things. Follow your child's lead. In the moment, things change. They might have made a plan with you and you're like, oh no, we made that plan, but they may not be ready to like take that plan out. So I'm looking at the time there now, there's loads more. Interactions, positive adult interactions can minimize distress massively. The big thing that I suppose parents and professionals that I'm always saying is our communication. 93% of our message is actually nonverbal. So 7% is only speech. So what we're saying doesn't really matter all that much. It's how we're saying it and how our behavior is and our nonverbals around it. So if you're saying things through gritted teeth and high tones, and this, children are reading all of that. I, again, would change my tone and things. I'm like, oh my goodness, you're getting an NG tube. My friend got that last week. And I have this like high excited tone about it. It's not the, well, you're going to get an NG tube now, and the serious tone. And I'm there. But like, I know people, oh, that's my timer to tell me to slow down with the talking. I use timers all the time. So I have this beautiful timer that you can get and you can move it. And then the red decreases down on it. So you can actually see the time disappearing and then a lovely alarm goes off. I need timers because I talk an awful lot, and I'm going to move to these positive bits. I don't know, we're running out of time, but these are really important. So the interaction strategies: observe, wait, listen. So observing your child, waiting and giving them time, not stepping in too quickly. They will take longer to communicate with you in this environment. You might have a very able, articulate, communicative child at home. In here, take that back. You might have a child that already has communication needs in their everyday life. That's going to be amplified even more when they come in here. And as a parent, you're kind of like, what? But they can do this. They can say, but in here, their fear is taking over. They aren't at the same ability because of the fear factor. So taking that into consideration, waiting, listening to hear what they're actually going to say, not what you think they're going to say. And give it time to listen back and repeat what you hear them saying. Reiterate it back. Oh, you're worried about this part. Again, that's for them to go, yeah, mommy's listening. She hears me. Or daddy knows that's what I mean. You need to validate the emotions massively. So I will always say, oh, buddy, I see you're really sad. Or you're really worried. Oh, no, your breathing's gone really fast. Let's bring that back first. Then we can talk. So it's naming those things. And when we wait for 10 elephants. So our counting, I don't know about all of you, but I'm a very fast talker. I'm from Cork and I go super fast. And when I'm talking about this kind of stuff, I talk extra fast because I'm very passionate. But we need to slow it down and count 10 elephants. Tips for the home: providing access to play resources. But again, at their thing, leave them initiated. It's not that you're initiating medical play with them. The resources are available. They'll pick it up if they want. Again, similar, Lisa, even having the books available and not picking them up, but having them available that if he wants to look at them, he can, or she, is it a boy or a girl? But whoever has them, you don't always. So the lady I spoke to this morning, she said the sisters really loved the book, but the child herself didn't. But because the sisters were reading it, the child still heard it. And the sisters loved it because they wanted to know what their baby sister was happening to their baby sister at school or at hospital. Let them lead the play. So if you are playing, let them lead the play and actually be more of an observer in the play than actually overly participate. No, it isn't that you don't participate, you do participate. But again, being it like more of a mirror and mirroring back what they do or repeating what they do. Comment on what you see is happening. Oh, I see your Lego man has gone into the tunnel. They're reenacting that they were in the MRI. Again, I just name it. I don't question. Questions are putting a communication demand on a child. Creating a document. This is really important. So when you're going to A&E, have a list of your child's medications, have a list of their medical history, have that in your handbag, have it on your phone, have it somewhere easily available so that when you go in, you can give that to the medical person. So you don't have to be talking to the medical person and saying all that when your child is needing your attention, needing your support. And again, they don't need to be hearing all this. This is a lot of verbal clutter that's heightening their fear because there's too much going on. You need to be able to give them all your attention and what they need in that moment. So by having that document, that alleviates. It also alleviates the fact that you might forget certain things because you yourself are going to be stressed, especially if it's an A&E visit. You will be stressed. I would always say write down lists of questions you have for clinicians, questions that the child might have for the clinicians if they're coming to clinic. Bring a favourite teddy or comfort toy that they may like. So I have Spider-Man up here because I have a little boy that I call Spidey. Create a bag of resources, specific bags for hospital only, because some children can get quite triggered if they see that coming out. So the little girl I spoke about today, her mom was like, oh my God, Rachel, she saw the lunch bag that I had in the hospital the last day and she got all upset thinking she was going to the hospital. I was like, yeah, we need to make one hospital bag and then our lunch bags for something else. This is the This Is Me document. So this might be helpful, Lisa, there for your child to have all this information to be able to share with the medical teams when you come in and knowing what, and again, what the child would like you to know about them. So this is something that we're rolling out in Cork. So if you're coming into CUH, you can ask for this document. You can fill this document out. I like this to be done with the child or the child to do it themselves if they can or if they want to. But very dependent on the child. It depends on their age, their abilities, their needs. They may not want to. Totally down to them. But it is really important for us as a medical team in the hospital to have the information. I won't even go through what helps Spidey now because I'm going to have to leave some questions because we're running right over. Be an active participant, involving him in medical routines. Spidey was a little boy who's obsessed with Spider-Man. He calls his Spideys his Freddy lines. His Iron Man is his port. Validating emotions are massive. I've touched on it all already. Language. Sorry, I'm very bad. I'm gonna finish on the language part. Things like saying it will not hurt. If we change that to things like we all feel differently. I don't know what you're going to feel. When I get it done, it feels like this because you don't know that they won't feel it. Some children are hypersensitive to touch. Replace it's okay with something like, I see this is hard for you. We can do this. I've got you. Because if we're saying it's okay and the child's not feeling okay, that's not positive for us to be saying they're okay when they don't feel okay. Be brave can be a hard one as well. So if we can say, replace it with, we can be brave together. We've got this. We're a team. Validating the child's emotions, naming it, and avoiding the word but. So if I say to you, I know this is hard, but I've already nearly dismissed the fact that I've said it. I know it's hard. So if we can say, I know this is really hard, it's important that we get it done. If I take out the word but, it puts much more kudos on what I said first. I hear you. I know it's hard. And we are going to get this done together because we're super brave and we've got this and I have you. Really important. Now I'm going to ask for questions. I'm sorry, I talk for Ireland.
Thank you so much, Rachel. I'm going to stop recording now and then we go to the questions.